There is certainly a need. And then we have.
Welcome back to MICE TV, coming to you live from the CAKE PIE Expo in Da Nang, Vietnam. Joining us now is Dr. Samita Moolani from Moolani's Eye Care Center in Pune, India. She's a general ophthalmologist specializing in cataract and cornea. She's just finished her talk during the CAKE Symposium, Pearls for Complex Cataract Cases at CAPE 2.0. Welcome to MICE TV, Dr. Moolani.
Thank you very much. Thank you for having me.
Yeah. So before we get into it, how are you doing? When did you arrive to Vietnam?
I got here yesterday and attempted to go up to the Golden Bridge.
Oh, how did that go?
Failed.
Oh, why did it fail?
It was rainy and there were thunderstorms, but that's okay. We got some shopping in and you know, it's a beautiful country.
Yes. And how long do you get to stay in Vietnam?
Another few days. I'm going to go off to Hoi An.
Oh, yes. Yeah, you definitely have to see the ancient city.
Yeah, yep. And the Lantern Festival is tomorrow, I believe.
Really?
Oh, wow. I didn't even realize that.
I miss it.
We'll be here, MICE TV. All right, well, let's go ahead and jump into kind of what you were discussing today. So your presentation, it's not over until it's over. Cataract surgery, or what is it? Cataract surgery, not so simple.
Right.
You had some great cases, and you had a boxing theme, which I loved. I think we've got a video. Do we have that?
To the winner by majority decision.
Hey is the WBA heavyweight champion of the world. What a moment!
So that is Dr. Moolani after she is successfully fixed a complex case.
That's right.
So, you know, I watched your presentation and these surgical videos, and the only thing that I could think to myself is that you must have nerves of steel. You know, what are some tips for staying calm when the unexpected happens?
You know, it's funny you say that, Brooke, because a lot of times when we're operating and we have these complications, I ask my anesthetist as a joke, obviously, that maybe instead of monitoring the patient's blood pressure, you should be putting a cuff on me because I'm pretty sure I need monitoring, you know. But in all seriousness, it takes practice, it takes time. When you're a new surgeon, it's easy to flip out, freak out. But most times you have the support of other surgeons to, you know, take over from you and help you. I think another tip is to observe some of the best surgeons in the world. So I always tell young novice surgeons, go out and observe, spend time in operation theaters where other doctors are operating. Because when you see them and you see the way they manage their nerves, the way they, you know, have breathing techniques, you know, their routines, it's so beautiful to learn from that and imbibe that, you know, that culture. And I'm not just talking about Indians or Asians, but all over the world. You'll see every brilliant surgeon has like a morning schedule. They have a routine. They are also doing yoga. They're also exercising. And all these other things bring to you a sense of kind of focus and calm when you are faced with these situations.
You know, and that's a really interesting point that you make. So it's not, I mean, obviously the surgical skill and technique, that is very important.
Of course.
But it's also about stress management techniques.
Absolutely.
And how you react when these situations come up.
Absolutely.
So let's talk about maybe your first experience having one of these complications, perhaps when your mentor wasn't there.
Right.
How did that go? What was the complication, if you can recall, and, you know, what kind of went through your head?
Yeah, so the first time I had a complication where I didn't have anybody to kind of back me up was a black cataract, and I basically ended up with an entire zonular dehiscence, and the cataract was literally sinking down, and my heart was also sinking down with the cataract, and you know, I knew that this is not going to go well.
Right.
So, you know, sometimes you need to just put aside your ego. Instead of overdoing things, you need to know where your limits are, and that's what I did. I took the cataract out entirely because as a novice surgeon, I didn't know what else to do. I just cleaned up, you know, the anterior face, and then I closed up the eye, and then I referred or called in the, you know, the retina specialist to take over because I knew that this is not something that I'm going to take.
So when the cataract started to sink, you obviously knew that it had gone to the
Yeah,
posterior
and
segment.
I had lost a lot of it, yes, down there. So I was like,
Right.
you know, I need the help.
Well, and that's another thing, too. It's all about knowing when to call in maybe, you know, a
Exactly.
vitreoretinal surgeon or somebody who
Absolutely.
specializes in something else to
Yes,
come and step in.
absolutely.
Yeah, so do you have members of your team that you're always ready to call in a situation like that? Do you have a list or?
I do. I have a onboard retina surgeon who would come in and kind of rescue the situation. Sometimes they may not be able to do it on the spot. So for us, we may have to, manage it until he can come in. It may be later the same day, maybe a few days later until the eye is a little more stable, the corneas are clearer. But yes, you should always have a backup retina specialist if your specialization is anterior, because the reality is more often than we realize, even the best cataract surgeons in the world do have complications.
Absolutely.
Because the more you operate, the more you complicate. That is the reality.
A surgery is a surgery,
Absolutely.
even though it may be routine.
And that's exactly what my talk was about. My talk was about the fact that things will always go wrong. So you need to just be prepared to manage them or hone in that skill, and if you don't have it, then you pass on
and take
that
a breath.
absolutely
Very
take a
good.
breath.
Well, that you talked about your talk, so let's talk about the other speakers during your symposium.
Right.
There were some really interesting talks, especially if you're more of a novice cataract surgeon.
Absolutely.
Dr. Hook, he was first, and I believe he talked about his top 5 phaco tips. Now, we're not going to go into all of that right now, but I'd like to hear, for a young surgeon, your number 1 tip for someone starting out with phacoemulsification. What would you say to them?
I think Dr. Huck made one of his points was very important, and when you're starting out as a phaco surgeon, you need to know your machinery, because you've already learned, hopefully, tissue handling, you've already done some conventional, you know the eye, you understand the field, but you have no idea what that phaco probe is capable of.
Right.
And it can do brilliant surgery, but it also creates a completely different set of complications, right? Like people who do manual small incision and never do phaco, which we see a lot in Asia, because a lot of places just do manual small incision. They have no idea how powerful that phaco probe is.
Right.
And so that is, I feel like that's the most important thing. Understand your machine, understand your phaco dynamics, and one of my key points is go and learn. Student for life, no ego.
Yeah.
You need to just keep learning. And
it's
at
a
every
medical
single
practice.
stage of your career, you should still be learning.
Definitely.
Yeah.
Okay, great. Well, and then we'll continue the learning, and Dr. Moodley, she talked about ocular surface disease. And, you think about, oh, it's dry eye. What does that have to do with my cataract surgery? But it can really throw off measurements. And, what are some other ways that having ocular surface disease can affect outcomes after cataract surgery?
So you're talking about preoperatively, it can completely throw off measurements, but a lot of the cases that we see postoperatively suddenly develop the meibomian gland dysfunction, and suddenly they keep saying, my eye was fine. Okay, I couldn't see, but I was comfortable, and now I have this nagging, poking sensation in my eye, and then for the rest of their entire life or few years, they keep blaming it on you. So she rightly pointed out that you need to manage it operatively as well as post-operatively with all the different technology that we have and eye drops that we have today. And there's a huge spectrum.
There is.
Dry eye needs to be taken way more seriously.
Right,
than
and I think it's getting the attention that it deserves now.
It is,
It
it
is.
is, yeah.
Well, one more thing. Dr. Ben Lahood, he talked about Toric IOLs.
Yep.
So, I know Toric IOLs, they're more of a premium option. They may not be available to every patient and every doctor. So what is your threshold, is there a certain amount of astigmatism you'll tolerate in a patient, or do you always kind of want to push them into that toric lens to help improve their vision?
So usually for me, somewhere between 0.5 and 0.75 is where I kind of push it, but definitely at 1, I will kind of really push the patient, because I try and explain to them that every distance of vision you're going to need to be aided, and that just doesn't make sense. Luckily for us in India, we do have local made toric lenses available to us.
Great.
It is slightly more expensive, but it is easily available to the patient. So we can also cater to the mid-level budget of the patient. So you should still, I feel like above 0.5 cylinder, you should counsel every patient. Of course, if they still can't afford it, then you do the best you can.
Okay, well, that's very good. We're just about to sign off for this segment. Can you just tell me one thing about what you're looking forward to at the expo today? Anything else that, I know we have a party tonight. Will you be going to the Orbis party?
Yes, I will.
Excellent.
You know I will.
Yes, fantastic.
Can't wait.
All right, so I guess we'll sign off for here. What do we have up next, Matt?